Welcome, everyone. Thank you for joining us tonight. My name is Ayana Woods. I'm the Executive Director of End of Life Choices New York. End of Life Choices New York is the leading organization in New York working to improve end of life care and expand end of life options to ensure peaceful death. And we're so excited that you joined us tonight for our webinar, Stories of Assisted Dying in America, New Narratives for Old Debates. We're so honored and pleased to have Mara joining us tonight. Mara Buchbinder is a professor and vice chair of social medicine and adjunct professor of anthropology at UNC Chapel Hill. Actually, that's where I got my master's, so I'm excited about that, as well as a core faculty in UNC Center for Bioethics. Dr. Buchbinder is a medical anthropologist with broad interest in cultures of health, illness, and medicine in the United States. Her recent work focuses on how patients, families, and healthcare providers navigate social and ethical challenges resulting from changes in medical technology, law, and health policy. She's the author of 3 books and 2 edited volumes, including her most recent book, what we're going to talk about tonight, Scripting Death, Stories of Assisted Dying in America, which was published by the University of California Press last spring. And in 2015, she was selected for the Greenwald Faculty Scholars Award, a career development award, which enables junior faculty to carry out innovative bioethics research. And in 2017, she received a Philip and Ruth Hedelman Prize for Artistic and Scholarly Achievement by young faculty at UNC Chapel Hill. Her research has been funded by the National Institutes of Health, the Centers for Disease Control and Prevention, the National Science Foundation, and the Greenwald Foundation, along with the Warner Gren Foundation. So please help me welcome Mara to talk today. We're really excited to hear and learn more about your research and your amazing work that you've done over the past couple of years.
Thank you so much, Ayana. It's really wonderful to be here with all of you. I am going to share my screen. Okay, so I'm just really delighted to be here, and I'm so grateful to Ayana for the invitation to speak with you tonight. So I'm going to be talking with you tonight about research that I conducted between 2015 and 2017 on Vermont's medical aid in dying law. And in the course of that research, I collected hundreds of stories about the desire for choice and control at the end of life. And those stories have really helped me to rethink some of the dominant public and media narratives around medical aid in dying. And that's really what I'd like to discuss with you tonight. So just to start, I want to acknowledge my funding support by the Greenwald Foundation, the National Science Foundation, and my department at UNC, as well as support from my wonderful research assistants. And I am, let's see, okay. I'm gonna start by telling you about 2 cases. And the first is about a woman whom I'm going to call Frances. All of the names that I'll use tonight are pseudonyms. And I had the pleasure of meeting Frances in her home several years ago. She was in her 60s and she had been living with ALS for several years. And I walked into her home, which was this beautiful rustic log cabin that she planned to retire to with her husband. And she was sitting on the couch waiting for me, and she handed me a note. And she had written out a note because her ALS had so severely impacted her speech at this point that she was communicating primarily via iPad. So this is the note. Whoops, my transitions are going, okay, there we go. And I'll read it for you. The note said, I've been a critical care RN 1975 to 2015. Seen many patients die on respirators, tied down, pleading eyes as I give meds to settle them, but who knows what they were thinking trapped like that. Families coming and going, exhausted. In acute care, some patients would never go through what was going to happen to them if they had the choice. But once that starts in that setting, there's no going back. They die attached to tubes, feedings, incontinent, no communication, tears sliding from corners of eyes. Many patients and families need to have this option. It's our bodies and lives and should always be our choice. When and how we die is our right. I would advocate for my patients with no hope at all, but would be endless discussions with their team of doctors, then each specialist weighing in, then palliative care, then family meetings, on and on. But the one person left out is the one dying slowly who was never given a choice. And Frances went on to hasten her death using medical aid in dying a few weeks after we met. Now, this is an email that I received from a prospective study participant in April of 2017, and I'll call her Margot. And she had heard about my study from a hospice volunteer that had helped to take care of her husband as he was dying. Her email to me read, "My husband died 1 year ago. He suffered from a chronic disease for which there was no cure. He very much wished to have a dignified, pain-free death on his terms and was hopeful that Act 39 would make that possible." And Act 39 is the name of Vermont's medical aid in dying statute. "We were shocked to learn that our local hospital prohibits its physicians from participating in Act 39. An exhaustive search elsewhere in Vermont was no less promising, as we were informed by several physicians that heightened scrutiny in Vermont made them reluctant to participate. At a time when I should have been comforting my dying husband, I was desperately trying to navigate Act 39 on his behalf. I regret that it took me from his bedside. I think Vermonters would be shocked if they knew how inaccessible Act 39 is." And when I interviewed Margot in her home a few months later, she told me, "I feel really badly that Vermonters are under the illusion that Act 39 is available to them. And it really wasn't," was my experience. So what I want to suggest to you tonight is that these two vignettes really represent two distinct faces of medical aid in dying. Frances's story is the one that tends to be emphasized in advocacy discourse. So we have a terminally ill patient desiring to control the timing and circumstances of her death, who requests assistance from a trusted physician who will then accede to the patient's wishes. And some of you might recognize this photo. This is Brittany Menard. In 2014, at the age of 29, she became the new face of the assisted death movement when she moved to Oregon and established residency there in order to make use of the state's death with dignity law after being diagnosed with terminal brain cancer. But one of the goals of my research has been to bring to the foreground the gaps between these advocacy narratives and what actually happens once medical aid in dying is put into practice, and some of the lesser known narratives that surround that. So this right here is a picture of Judy Dale, whose family sued the UCSF Medical Center in 2016 for allegedly misleading Dale into thinking that they would be willing to prescribe lethal medication to her under the state's medical aid in dying statute. And in my view, both of these stories, as well as those of Frances and Margot, are really central to understanding medical aid in dying as a new medical frontier in the United States. And the goal of my talk tonight is to foreground some of these previously hidden narratives. So my plan for the talk is as follows. I'm going to start with some background on medical aid in dying in the US and tell you a little bit about my research methods. And then I'm going to tell you about 3 previously hidden narratives about medical aid in dying. So the first is the access narrative, which we've just been talking about. And the dominant narrative surrounding access to medical aid in dying really suggests that legalization is the main impediment. So you might have heard this in New York. Why shouldn't New Yorkers have access to the same kinds of options that their neighbors in New Jersey or Vermont do? And this narrative really suggests that once medical aid in dying is legalized, patients will have access to this option. But my research in Vermont really suggests otherwise. And so I'm going to show you this evening that patients encountered a range of barriers to accessing medical aid in dying once it was legalized. The second narrative concerns the role of physicians' participation in medical aid in dying. And according to this narrative, participation for physicians is an all or nothing proposition. So physicians are seen as either for or against medical aid in dying. They either will prescribe or they won't. And what I found is that physicians had a wider range of stances toward medical aid in dying and often had quite nuanced views towards the practice. And then finally, the dependency narrative suggests that terminally ill patients pursue medical aid in dying because they don't want to be dependent on others for end-of-life care. So from this perspective, we can kind of think about medical aid in dying as an act of radical individualism. Given this narrative, I was somewhat surprised to find that medical aid in dying is actually an extraordinarily relational practice. And it's one that fosters new forms of sociality, even as it permits people to avoid certain kinds of dependency. So there was really an interesting paradox here that I've explored in my research. And finally, I'll conclude with some brief thoughts about how these new narratives can help to reframe old debates about the right to die in the United States. So the legalization of medical aid in dying in the US has proceeded at the state level, beginning with Oregon's Death with Dignity Act, which was passed in 1997. And that same year, 2 Supreme Court decisions rejected the view that there was a constitutional right to die with the assistance of a physician. But really, these decisions left the door open for individual states to authorize the practice. The number of permissive jurisdictions in the US is now 11, making this end-of-life option available to a little more than 1 in 5 Americans. Now, in Montana, I've shaded Montana in a slightly lighter shade of teal on this map because the situation is a little bit different in Montana. It's the only state where medical aid in dying was legalized via a judicial decision, and there's no regulatory statute in place. Now, I want to stress this is really a rapidly moving landscape. New Mexico was the state that has most recently legalized medical aid in dying, signing their law into effect last spring. But 14 states, including New York and many of its neighbors, are currently considering legislation, are currently considering medical aid in dying legislation. And in addition to that, several states with existing laws have recently introduced or passed new legislation attempting to modify the existing laws. And in most cases, those modifications are being introduced with the goal of eliminating some of the safeguards and making access a little bit easier. Data from the last 20 years of research in Oregon suggests that most people who pursue medical aid in dying are not motivated by concerns about pain, but instead by concerns about a loss of autonomy and dignity at the end of life. So patients seeking medical aid in dying are really expressing a desire for control, to control both the timing and the circumstances of death. The Vermont law is the Patient Choice and Control of End of Life Act, and it was passed in 2013, making it the 4th state to legalize medical aid in dying. And I've put a picture here on the slide of then Governor Peter Shumlin signing the bill into law. And at the time that I started this research, Vermont was the state that had most recently legalized medical aid in dying. And that's really the reason that I decided to focus on it, because my interest was in understanding what happens when laws and policies are new and their practical significance is still being worked out on the ground. In many of the early phone calls that I made to stakeholders in the state, they would say, you really should go to Oregon because they've been doing this a lot longer than we have. And I had to explain that that was precisely why I was interested in coming to Vermont. Vermont was also the first state to utilize the legislative pathway instead of a ballot initiative or the courts. And Vermonters are quite proud of this fact because there was a lot of grassroots mobilization that really made this possible. And there's an interesting kind of history of the law that I write about in one of the chapters of my book. Now, the medical and legal requirements are largely identical to those in place elsewhere in the US. The law permits physicians to write a prescription for a lethal dose of medication to a mentally incompetent adult patient for the purpose of ending the patient's life. And there are safeguards in place. The patient has to be diagnosed with a terminal illness, which is defined as an illness for which death is expected within 6 months. There have to be 2 voluntary oral requests made, spaced 15 days apart. A written request signed in the presence of 2 witnesses, non-familial witnesses, I might add, certification of diagnosis and prognosis by a second physician. The medication has to be self-administered. And basically these measures are all designed to ensure that the practice is voluntary, while the practice is voluntary for physicians as well. So in January of 2018, the Vermont Department of Health released a report about utilization of Act 39 in the first 4 years, which very conveniently aligned with the period of my research. And so this gives you a little bit of a sense of the landscape. And you can see these frequencies are very low. Vermont is a small state. It has a population just over 600,000. And during this time, paperwork for 52 patients was filed. Most of these were cancer diagnoses. And at the time the report was filed, 60% of the patients had died as a result of ingesting the medication. These numbers really didn't rise very much in the subsequent 2-year reporting period, as this second set of numbers from the more recently released report illustrates. And I like to show this because I think it highlights that it's really only going to be a small segment of people that are likely to experience medical aid in dying for themselves. At the same time, I think the practical significance of medical aid in dying stretches much further than these numbers suggest, because it tends to be discussed far more often than it is performed, and it can often serve as a gateway for introducing other kinds of end-of-life concerns. So there's a way in which I think it fosters changes in the broader conversation about control over dying and introduces new ways of thinking about possibilities for control over dying. My primary research methods included 144 in-depth qualitative interviews. All but 3 of these were conducted in person. Almost all of them were audio recorded. I also did some observations in conferences for Vermont healthcare providers, in public events organized by advocacy organizations, and there was a lawsuit that was filed during the time of my research that I followed to document ongoing challenges to the law. The lawsuit was eventually dismissed. One of the benefits of looking at this phenomenon in a small state like Vermont, because believe me, there were plenty of people who said, well, Vermont is such a small state, why does it really matter? But what it enabled me to do is to talk to most of the key players and most of the key stakeholders across the state. So I was able to interview a majority of the prescribers in the state and many of the key legislators that had worked to pass the law. And I talked to people all over the state. So the circles on this map indicate places where my interviews took place, with larger circles representing more interviews. And I think it's important to highlight this geographic range because access to medical aid in dying really looked different in different parts of the state. And it was important to understand how that was working out across different counties. And I'll tell you more about that as we move forward. So I'm going to transition now to talking about my findings. And the first part of the presentation concerns barriers to accessing medical aid in dying. So again, the advocacy and media discourse tends to suggest that legalizing medical aid in dying ensures choice at the end of life. But the reality is that many patients encounter substantial obstacles to accessing medical aid in dying where it's legal. And I'd like to share with you a little bit about why this is the case. So this is an overview of the barriers that I found that I'm going to tell you about tonight. And they include the legislative safeguards, the cost of medication, the process of finding a physician, access to information about the law, and social support. So first of all, the safeguards. The requirement that patients self-administer the medication was intended to ensure that the act was voluntary and that there was no coercion. But it proved to be a major hurdle for some patients, especially those with neurological conditions like ALS. And this is because ALS results in progressively declining mobility and often entails swallowing difficulties in the later stages of illness. So one physician lamented, why can't a hospice nurse administer the medicine for the patients if they can't do it themselves? That doesn't make sense to me. It seems like it puts undue stress on my patients, and it also prevents a patient who really needs this program from being able to access it. I feel like it was designed with the cancer patients in mind and not the rare neuromuscular patient like mine. And other ALS clinicians expressed similar views that the law sort of seemed to favor patients with cancer, though it's worth pointing out that some patients with cancer also have difficulty swallowing in the later stages of illness. So one effect of this requirement is that it sometimes encouraged patients with ALS or sometimes other conditions to choose to die sooner than they otherwise would have, so that they retained the capacity to ingest the medication. And this is one reason why Canada took sort of a different approach in their legalization pathway in authorizing physician-administered medication in addition to self-administered medication. Other access barriers tracked along more familiar lines of US healthcare inequalities. So the exorbitant cost of Seconal, which was the most common barbiturate prescribed for medical aid in dying at the time of my research, was a significant deterrent for some patients. And the reason it's so high is because in 2015, about a month after California proposed its medical aid in dying legislature, its medical aid in dying legislation, the Canadian pharmaceutical company Valiant bought the rights to Seconal and they jacked up the prices. So, some insurance companies have agreed to pay for it, but others won't. And for anyone that has Medicare, that's not an option because federal funding, including Medicare, cannot be used for medical aid in dying. Now, it's really important to emphasize that alternative drug protocols have since gained in popularity and are now being used much more frequently. But at the time of my research, physicians' knowledge of these alternatives was really uneven. And many continued to view Seconal as the safest and most effective choice. So one physician explained to me, it's kind of like a medical frontier, just because it's not done that much. And if they can't afford the more expensive but more effective medication, that doesn't feel right. So that kind of feels like a discriminatory burden. If you're not wealthy, you get the cheap stuff. This was probably the biggest barrier, finding a physician to prescribe. And things have certainly gotten better over the time that I've been working on this study and since I completed the study, but there are still certain parts of the state where it's very difficult to find a physician willing to prescribe. Now, the goal of policymakers was really to normalize this practice within normal pathways of care, especially primary care. So there's no state-specific list or Rolodex of willing physicians, but the idea that people could just go to their normal primary care provider and convince them to prescribe is a bit problematic because there's a primary care shortage in the state and many patients have nurse practitioners for their primary care. And this also excludes veterans unless they can afford private care due to federal restrictions on VA providers. In general, I would say access has been easier for patients who are treated at the UVM Medical Center, which is the only academic medical center in the state of Vermont. All hospitals are supposed to have a policy to help patients who want this option get linked up with a physician who's willing to provide it, but this has not been institutionalized in all of the smaller hospitals. And even at UVM Medical Center, it doesn't always work the way that it's supposed to. There's also a very big access problem in the southern part of the state where many Vermont patients are treated at the Dartmouth-Hitchcock Medical Center in New Hampshire. And of course, medical aid in dying is not legal in New Hampshire. I think it's also important to note that although access has been better around Burlington, which is the largest metropolitan region, access does not cut neatly across urban rural lines. And there are a couple of rural counties in Vermont where access has been very good. And conversely, a couple of the more populous urban areas in Vermont where it's been less good. And so in a small state like this, it often comes down to a couple of individual physicians and their willingness to provide this service to their community. Finally, social networks really matter for access to physicians, particularly in a small state like Vermont. So I want to return now to Margot Hadley, and she's the second case that I shared with you at the beginning of my talk. And this is what she had to say about the process of trying to identify a physician for her husband. She said, I contacted Compassion and Choices, which is the national organization that helps you access death with dignity. So they said I would just have to find, 2 doctors in Vermont to prescribe. So I said, okay, great. Could you tell me what doctors have been prescribing? No, we can't tell you that. I said, well, how am I supposed to find 2 doctors? I just can't go knocking on their doors. I'd have to transfer all the medical records, and they're not going to meet with me or with my husband without all of our records being transferred. And I can't do that 30, 40, 50 times. Now, it turns out that after this conversation, Margot did actually find a physician willing to prescribe, in part because she had a personal connection through her former in-laws, who were dear friends of a physician who had prescribed for medical aid in dying. And he agreed to meet Margot and her husband, Rich, in his office on a Sunday, which Margot explained to me was to conceal this visit from clinic staff. So it was veiled in secrecy from the beginning. He agreed to prescribe, and Rich left the office quite elated. But after a week went by, Margot received a call from the doctor who had said he had changed his mind. And he apologized, and he said the scrutiny in Vermont has just gone through the roof, and people are going to think that you're doctor shopping. And Margot said to me, I am doctor shopping. That's the truth. And ultimately, Rich was not able to access medical aid in dying. These access gaps were very difficult for nurses that care for these populations as well. So there was one oncology clinic nurse practitioner in a part of the state where access is very severely constrained. And she was just visibly distressed in talking about how she had to navigate this with her patients. And she said to me, I think the perception among many patients is that it's the law. There must be a way to access it. And later she continued, it's very nice to have this, but I think you don't have equity. You can use it if you're a patient who meets all the criteria and then is lucky enough to have a primary care physician who knows you and then is willing to participate. Access to medical aid in dying is also shaped by patients' differential access to information about it. So these headlines on the slide here suggest that the clinical standard has really been for physicians to wait for a patient to initiate a discussion of medical aid in dying. And there's been this implicit presumption in the literature that communication about medical aid in dying always begins with the patient's request. One physician explained the practice to me like this. I think because it's new and people are sensitive, people pretty much across the board feel that it needs to be a patient-directed question. I don't know of anybody who would put that on the table before somebody asked about it, for two reasons. Number one, the population that's going to ask about this, they're a savvy population. They're people who really want control. They're going to know about it. They're going to ask. And the people that aren't going to ask may be less likely to be interested. So that's the way that I think about it. So physicians and bioethicists tend to view this practice of waiting for the patient to initiate the discussion as an important safeguard to ensure that medical aid in dying is voluntary and that it's not subject to healthcare provider influence. But patients can't ask about it if they don't know about it, right? And survey data from Oregon suggests that public education can really lag far behind legislative developments. And so because more educated patients are more likely to be informed about medical aid in dying and be the ones to actually initiate a conversation about it with a physician, access can be stratified along socioeconomic lines. It's worth pointing out that this differential access also applies to physicians. I found in the course of my research that physicians' knowledge of the law and the various medication protocols really varied, and sometimes this was to the detriment of their patients. So I'd like to tell you about how this issue played out in a particular case. I met a man named Craig Lawson. Again, if you're joining late, all of my names are pseudonyms. And he told me about a friend and neighbor, Ron, whom Craig had helped care for when Ron was dying of cancer. And Ron learned about medical aid in dying from his hospice nurse, who had cared for two other patients that actually utilized Act 39. And Ron tried calling his oncologist to ask about it, but she didn't return his phone calls. And at that point, it was too late to find another physician. So Ron lamented that he could have used this option if he had started the process sooner. And this is what his friend Craig told me. He said, I felt like there was two things that were wrong. One was the knowledge that it existed. It was like a secret. And then the other thing I thought was not right was that because apparently his oncologist was not for it, she didn't really pursue it aggressively. And then he went on to, compare the situation to that of abortion, where legal status does not ensure access. And he said, it's like the law that you could have an abortion, but you can't find anybody, so you have to go in the alley, right? It's the same idea. Finally, social support was essential for navigating the bureaucratic protocol and assisting with all aspects of medical aid in dying, from identifying physicians to completing the paperwork to picking up the prescription from the one pharmacy in Vermont that would fill it, and just generally being an advocate for patients. One physician prescriber told me about a patient for whom she wrote a prescription for Seconal, but the patient's father could never bring himself to fill it. So one physician told me they need a good advocate for them if that's what they really want. So just to recap, there are a range of barriers in place to accessing medical aid in dying in Vermont: safeguards, cost, finding a physician, access to information, and social support. And based on these findings, I've argued that access to medical aid in dying is stratified based on socioeconomic privilege. And what I mean by this, I think, is nicely summed up by this quotation from a physician who said, "The situation is very elitist. Someone has to have the intellectual wherewithal to track down a physician who's willing to prescribe and follow through with that. They have to be able to track down a pharmacy that's willing to dispense medication, and they have to be able to afford it. And most people who are in the last 6 months of life who meet the criteria to go through with this, they don't have the resources intellectually, cognitively, emotionally, financially. So it limits it to a very, very small group of people. And it seems not fair that way too." Now, it's important to note that these access barriers are not unique to Vermont. This is just a selection of some of the headlines that we've seen from places like Colorado, Hawaii, and Washington, D.C., addressing patients' obstacles in gaining access to medical aid in dying in all of these sites. So the next narrative that I want to tell you about concerns the physician's role in medical aid in dying. And the narrative that I want to challenge here comes primarily from the research literature. This is an area where we don't tend to hear quite as much about it in the public narratives. But the research literature tends to characterize physicians as either starkly for or against assisted death. And consequently, it tends to portray their involvement in these practices as an all or nothing proposition. And I really found a wider range of engagement and participation, and that's what I want to highlight for you in the next couple of minutes. So it's a lot of responsibility and power to give people a script that they can end their life with. This statement was uttered by Dr. Alana Reynolds, a hospice and palliative care physician, and she went on to tell me how, as a hospice medical director, she really felt the need to take some sort of a stance on Act 39 after it was passed, yet also support a diverse set of opinions about it because it was a polarizing issue and she didn't want to alienate any of the patients in her hospice facility. So what she decided was that it was really important to truly understand her patients and to understand where they were coming from. And after a series of really intimate conversations with a few patients, some of which really challenged her previously held views on medical aid in dying, she ended up coming out in support of it for the right patient, is how she put it. And I start here because I think that Dr. Reynolds' experience was typical in the sense that many of the physicians that I encountered were not starkly for or starkly against assisted death in the aftermath of legalization. Many of them had quite complicated feelings about it. And those feelings tended to evolve over time through direct experiences with patients. Prior studies of physicians' interactions with medical aid in dying have tended to focus on their willingness to prescribe or how they respond to patients' requests. And I found that physicians, nurses, and social workers engage with medical aid in dying in a variety of ways that extend beyond responding to requests or deciding whether or not to prescribe. And importantly, even if a physician ultimately declines to prescribe, she may participate in other domains of care. So just to show you a little bit about how this worked out, I identified 5 domains of physicians and nurses' participation in medical aid in dying. Communication entailed exploring the reasons for the request and probing for alternative means of addressing them. In terms of the protocol, providers emphasized that understanding the law is time-consuming and there was a lot of bureaucracy that went along with it. Obviously, prescribing is an important component of participation, but it was far from this one-time event of writing a prescription on a script pad, because it often required consulting with physicians in other states, doing research to figure out what the protocol was. It was often a very involved process. And then providers often engaged deeply in planning for the day of the death and making contingency plans in case things went awry. Some of them even participated in the death, were present for the death if the patient wished. And then finally, several physicians expressed a commitment to educating colleagues about the process, both formally and informally. So I want to tell you about a couple of these physicians and what their participation looked like in different cases. Dr. Rhodes had worked as a hospice and palliative care physician for 11 years in a small, very rural community. And she had been drawn to this area of medicine after experiencing several significant deaths in her family in her 20s. Dr. Rhodes had navigated the Act 39 protocol with 4 patients, 2 of whom ultimately ingested the medication. When it first came up, she was surprised by her ambivalence. She viewed prescribing as a tremendous moral and emotional responsibility, and she did not take the decision lightly. Yet she understood the patient's choice and thought it was rational because it reflected the way that he had lived his entire life. Moreover, she was committed to non-abandonment, and she was convinced that if she didn't write the prescription, he would end up taking his life in a more gruesome manner. For Dr. Rhodes, the moral and emotional burden of medical aid in dying was a critical part of the practice. She thought that it was supposed to stay hard because that would protect against abuse. And she really resented those who viewed her participation as a denigration of the physician's professional role and felt that they didn't understand the thought and care that went into this work. So Dr. Rhodes is one of the physicians who saw her work under Act 39 as a clear departure from ordinary clinical medicine. And she found it incredibly emotionally consuming, and she didn't take her participation lightly. At the same time, she considered it a necessary expression of her commitment to non-abandonment. Now, Dr. Jones was another hospice and palliative care physician, and she was also committed to not abandoning her patients. Yet it led her in a slightly different direction than Dr. Rhodes. Dr. Jones was a hospice and palliative care physician whose clinical work was split between primary care and palliative care consultations. And when a patient asked her whether she would be willing to prescribe life-ending medication, Dr. Jones felt conflicted. On the one hand, because she strongly believed in the capacity of hospice and palliative care services to provide excellent care for dying patients, she was at least partially inclined to view these kinds of requests as a cop-out pursued by patients who had not truly exhausted all of their options. On the other hand, Dr. Jones was committed to the ethos of patient choice, and she didn't want to abandon this long time and very much beloved patient during a difficult time. Dr. Jones ultimately decided that the best way to navigate these conflicting values was to do everything possible to help this patient short of actually writing the prescription, which she viewed as crossing a moral line in the sand. So she assisted the patient in identifying a physician willing to write the prescription. She agreed to be the consulting physician, certifying that the patient met the legal requirements. And she worked with the prescribing physician to make sure that contingency plans were in place for the day of the patient's death. So Dr. Jones objected to medical aid in dying, yet the very fact that it existed as a legally permissible option made her feel some responsibility to help patients pursue it if they desired it. And this was really interesting to me because the dominant public narratives tend to characterize physicians' participation as an all or nothing proposition. Whereas Dr. Jones really found this ethical moral ground that allowed her to reconcile her opposition to this choice with her deeply felt personal and professional obligation to help her patient receive the kind of care that she wanted. So the last narrative that I want to tell you about concerns the role of independence and individualism in medical aid in dying. And it's true that people who pursue medical aid in dying tend to want to avoid being dependent on others for bodily care in the final stages of illness. But I think this notion downplays the extent to which medical aid in dying is actually a deeply relational practice that requires a lot of social support and buy-in from others. So despite this fixation with independence, which I think is a very sort of American fixation, people can't actually accomplish assisted death on their own. And the last part of my talk focuses on these social dimensions of medical aid in dying that I think are very important, but also very under-recognized in the public conversations about medical aid in dying. So one of the richest and really most interesting parts of this research for me has been hearing about how people plan and even choreograph their deaths when given the opportunity to do so. And this is a photograph of Betsy Davis, a 42-year-old woman diagnosed with ALS who chose to die using California's End-of-Life Options Act in 2016. She was not in my study, but I've taken this picture from some media reports. And the story is really remarkable because Betsy invited friends and loved ones to a 2-day rebirth ceremony, and that's what she called it. And she died on the side of a hill as the sun was setting, which was her choice. And to me, this scene looks like nothing more than a wedding. We see kind of the people dressed up and the tent and the white folding chairs. And I just find it really, really interesting in thinking about the ritualized elements of these kinds of deaths. And this, of course, was a really extreme example. I didn't hear about any deaths like Betsy's in the course of my research, but there were several elements in Betsy's death story that were commonly present in the deaths that were recounted to me in my study. And these included the presence of close family and friends, a sacred atmosphere, though this could range from joyous, as we see here, to more somber. There was often a ritual element like a final toast. And all of these deaths occurred in a non-medical setting. And this is because in Vermont, the law permits medical institutions, so hospitals and skilled nursing facilities, to prohibit patients from ingesting lethal medication on their premises. And almost all of the facilities in Vermont have taken this exemption. I think there's one continuing care retirement community that will permit patients to ingest on their premises. But this means that this is always, for the most part, happening in domestic settings and not in clinical settings, which I think is really important. So I'm going to tell you about 3 of these deaths. Bennett Tucker, a man in his late 70s, had endured a slow decline after a long-term cancer diagnosis. In his last 2 years, his symptoms had worsened and his quality of life deteriorated. For years, his wife, Noreen, had dutifully helped him navigate clinical trials and chemotherapy, but bathing, dressing, catheterizing, and moving him had become physically taxing, and she was discouraged that he was not getting better. Noreen felt she would soon need to get full-time nursing care in the home when Bennett announced that he was ready to take the life-ending medication that they already had on hand. To prepare for his death, Bennett was discharged from a local inpatient hospice facility where he had been admitted for a short-term pain management stay. And on his second day home, a physical therapist came to work on Bennett's pain, which was a side effect of the bone metastases. And she helped him walk outside to sit on the deck in the sun, fulfilling one of his last wishes. When he came inside, Bennett climbed into his bed and he said to Noreen and his 3 children, "What are you waiting for? Let's do it." And they had expected him to wait another few days, so they were surprised by this sudden decision. After calling Bennett's best friends to say goodbye, Noreen and their children surrounded his bed. They told Bennett they loved him, and his son, a physician, left the room to prepare the medication, adding Gatorade for flavor. Bennett drank the mixture quickly, as he had been advised by his physician. And as he swallowed the last few drops, his family told him that they would miss him, and Bennett closed his eyes. And it was as if he was falling asleep, no gaping mouth, no twitching, no nothing, just really relaxed, is how Noreen described it to me. In a matter of minutes, Bennett was gone. The next case was a female patient in her 60s, also with a cancer diagnosis. And she had endured a grueling course of cancer treatments several years prior. When the cancer recurred and metastasized, she was quickly drawn to the possibility of a medically assisted death. Now, Renee had never married, but her life was rich with friendships, with meaningful work as an artist and teacher, and a devoted spiritual practice. And her friends surrounded her when she died. When she went to bed the night before she died, she hadn't made up her mind about whether or not she was going to take the medication. And then during the night, her intense coughing echoed throughout the house. Finally, she got up at 4 a.m. She grabbed her laptop. She went back to her bedroom to pen love letters to friends. And at 6, she emerged and announced to her friends that had spent the night in her house that she was ready to go. While Renee said her goodbyes, 4 friends sat in a circle and they prepared the medication with a makeshift ritual ceremony. They used beautiful pottery and sacred chalices and emptied 100 capsules, which is the number of seconal pills required to form a lethal dose, singing while they worked, and carefully mixed the powder with juice. Then they all piled onto the couch for a final photo shoot, and Renee laid across their laps in a favorite leopard print and purple velvet outfit. And then in her signature no-nonsense style, she got into bed and started directing everyone on where to stand. They surrounded her as she drank, chanting softly, and 10 minutes later, she was dead. Now, I also want to share what I think of as a slightly less positive outcome. And for that, I'm actually going to refer back to Frances Sullivan, who's the woman whose note I started with. And Frances had ALS, and the ALS cases seemed to go somewhat less smoothly because of the mobility and swallowing issues that I've discussed already. Frances had been told by her physician that she had to be able to swallow the applesauce that she would mix the medication with in under 2 minutes. And on the day that I met her, she showed me how she was practicing. She had a bowl and she had these little individual sized cups of applesauce and a special spoon. And she showed me how she was practicing, and she had been doing it in a minute and 15 seconds, actually, is what she told me when we met. But in the last few days before she died, it was taking her 2.5 minutes. So she knew that the timing might be an issue, and her physicians had come up with a contingency plan. And the next excerpt that I'm going to share is from Frances's physician recounting for me what happened. So she said, I got a call around 5 a.m. from the hospice nurse saying she had fallen asleep. She couldn't swallow it. She got about half of it in and fell asleep, and so she didn't die from that directly. So she took it at around 3. At 5, the hospice nurse called me. The hospice nurse was going out there. I said, start the morphine, and hopefully it has replaced her enough that she'll have respiratory depression. But the hospice nurse was crying. She goes, this isn't how it's supposed to happen. And it was interesting because I didn't feel at all panicked. I was like, that was her path that she tried. It didn't work, but we know what she wants. She wants to be very comfortable. So we'll just start her on the morphine. And if we have to go any higher than 20 milligrams an hour, I'm coming out. And as I was going from my house to the hospital, she called and said Frances had died. So this is pretty typical for a bad outcome case. And I don't want to minimize it because prolonged deaths were typically very distressing for the family, and it could sometimes take even longer than the 6 hours or so that it took Frances to die. But that sort of distress was pretty much the worst case scenario. And even then, most caregivers were very happy with the outcome because it was meaningful for them that their loved one got to have the kind of death that they wanted. So I think these cases all highlight in various ways the fact that medical aid in dying is really an intensely social practice. And when I began this research, it was really surprising to me, in part because the dominant advocacy narratives that surround it tend to emphasize the desire to be independent in the final stages of illness, and also the ability to make an individual choice about one's end of life. And the deaths that I documented in my research revealed what I really saw as a critical disconnect between advocacy portrayals and the lived experiences of medical aid in dying. And they revealed how medical aid in dying is producing new forms of sociality and dependency around death and end-of-life care. And this is a major theme of my book, which was published last spring. And really, most caregivers described an intensification of intimate ties around planning for death and around the scene of death itself. They described it as this really intimate moment that bound together people that were present for the death. And I argue in the book that medical aid in dying is really remaking sociality, even as it sets about ending life. And this is something that sticks with the caregivers who live on to tell its stories. But I think the role of caregivers' assistance in assisted death remains largely underacknowledged in the public conversations that we have about medical aid in dying. Okay, so I'm going to sum up now. I hope that I've given you a new perspective on what I see as three of the dominant public narratives about medical aid in dying. So the dominant access narrative tells us that legalization is the primary hurdle to overcome on the path to medically assisted death. But the reality is that even after legalization, access is not a guarantee. And navigating access can be a very frustrating experience for many patients and their families. So I think my findings offer a cautionary tale regarding advocacy narratives suggesting that medical aid in dying legislation offers a clear-cut pathway to self-determination at the end of life. Now, identifying a physician willing to prescribe is often the biggest access barrier. But while physicians are often characterized as either starkly for or starkly against medical aid in dying, the reality is that for many, decisions about whether or not to participate are much more nuanced, and participation itself is not an all or nothing proposition. Finally, one of the strongest public narratives about medical aid in dying is that it's a choice for radical individualism born of a strong desire to avoid being dependent on others for end-of-life care. And I don't want to dispute the important role of independence and individualism in the choice for medical aid in dying, but I think my findings also highlight another dimension that is often left out of the public conversation. And this is that medical aid in dying is a deeply relational practice with important roles for caregivers and loved ones in witnessing and shepherding death. And these dimensions are often overlooked because of the concern about portraying the choice for medical aid in dying as an independent choice and one that's not subject to the influence of others. So I think there are some broader takeaway messages from my research that are relevant even in jurisdictions like New York, where medical aid in dying is not currently legal. American society has really witnessed a surge of interest in recent years in attaining control over death, but medical aid in dying is just one pathway for such control. We've also seen this kind of control manifest with increasing intentionality about planning one's funeral and burial practices prior to death, and other types of initiatives around end-of-life choices that End-of-Life Choices New York is currently engaged in. This control, I think, is oriented to several different things: relieving suffering or avoiding it in the first instance, maintaining coherence with one's life as lived so that there's a continuity between one's final days and one's ultimate death without a prolonged period of significant debility and decline, and achieving a subjectively defined good death. So that is one that reflects one's ethical and cultural and aesthetic values. So the cultural message here is that a good death is possible if we plan for it. At the same time, I also think it's important that we think critically about who gets the privilege of planning and examine the cultural values that underlie this expectation for choice at the end of life. And we need to acknowledge that not everyone will die at the end of a long illness, like cancer, for example, that affords the opportunity to plan for one's death. With that, I am very happy to turn it over to questions and comments. And I think I will stop the screen share now. Thank you.
Thank you so much. And I read your book. Can everybody see? Are we frozen?
You're cutting out, Ayana.
Okay. Can you hear me now? I was just going to tell everybody to type their questions into the Q&A box. I'm not sure what happened with my connection. Can you hear me, Mara, or no?
I can hear you. You're frozen, but I hear you.
Okay. Well, I'll take away my frozen face. But thank you so much for presenting on your book. Thank you so much for writing the book. You know, as you were talking, I was looking back to some passages I saw kind of in your conclusion. You write, when faced with the impossibility of choosing not to die, choosing when and how to die is empowering. An essential argument of your book has been that medical aid in dying enables ordinary people to establish control over the brute unwillingness of death. But it made me think about ordinary people as you were talking about how there's so many challenges in accessing it and who gets to access it. So I just like so many of your comment, concepts you discuss in terms of aspirational death and comparing access to abortion issues, and really the chapter you have about assistance and the physician's role, and how there's nuanced feelings. It's complicated, really, and there's a lot of mixed feelings there. And so as we think about kind of what's going to happen in New York State when it becomes legal, given the challenges and barriers you articulated in your discussion, is there anything that New York can do now in advance of the presumed legalization we're going to have to head off some of these issues related to the physicians, related to the narrative there, and access issues?
Yeah, I mean, I think, first of all, just education is huge, and that's obviously a huge part of the mission of organizations like End of Life Choices New York. So there has to be recognition that legalization is an important hurdle, but the work of advocacy organizations does not end with legalization. And so, in fact, that's when I think a lot of the important work just gets started. So working with physicians to make sure that they understand what the law is and sort of what the requirements are for them, working with the public to make sure that they know that this is an option, that they can inquire with their physician about, even if the physician doesn't tell them about it. And I think, some of these access issues might be built into legislative advocacy in places like New York before a law is even passed. So what we're starting to see is legislative changes in some of the states where medical aid in dying has been around for a lot longer, to do things like cut waiting periods, make it possible for nurse practitioners. In some cases, I think in New Mexico, they have permitted nurse practitioners to prescribe. So these kinds of modifications might be built into new laws before they even passed in order to liberalize access a little bit.
Mm-hmm. And someone in the chat asked if there's only still one pharmacy in Vermont that will dispense the medication. Is that true?
I am not totally sure what the current situation is with that, but I know that over time, since medical aid in dying has been around, for most of the time it was one pharmacy, and it was not always the same pharmacy. I would not quote me on that being the situation today, but I would not be surprised if it's still the case, because a lot of the national pharmacy chains have really been reluctant to dip their toes in these waters. And that might have to do with concerns about, if they're operating in many states, then how are they going to make policies that are specific only to states where this is legally available? So it has been the sort of private, smaller pharmacies in Vermont that have been doing it. But I'm not sure on what that is looking like in other states. And it's something that we could expect to see change as more and more states legalize medical aid in dying.
Mm-hmm. I have another question here that kind of talks about faith communities. Someone said, I was curious if your research turned up any issues related to faith communities, knowing that faith communities in New York are likely the ones that are the barriers to passing this legislation.
Well, Vermont is a fairly secular state, and I think that was significant in why they were one of the earlier states to pass legislation. I don't know of any faith communities in Vermont specifically that were very active in the advocacy opposing the legislation. The key ones that opposed were the Vermont Right to Life Society, and which of course does have connections with the Catholic Church, and then a couple of disability rights organizations. The Catholic Church has historically been one of the strongest opponents of medical aid in dying, but it's been right up there actually with the American Medical Association. So physicians' professional societies historically have been really dominant opponents. We're starting to see that shift a little bit. And there have been several medical societies that have come out in recent years to adopt a neutral stance on medical aid in dying, which, believe it or not, is a step forward from a stance of opposition. And there have been a couple, I think, that have endorsed an affirmative stance toward it. But I think, faith communities are likely to be some of the stronger opponents of the practice.
Mm-hmm. Another question that says, thanks for the excellent presentation. Sounds like your research could support the argument against medical aid in dying, given the issues with access, inequalities, physician resistance, et cetera. Wondering if you've seen anyone use your research to support the argument against it?
So interesting question. I mean, I guess I'm not aware of my work being used to oppose medical aid in dying, but I can see how that argument could be made. I mean, I guess one thing that I didn't say at the outset is sort of how I position myself in relation to this work. And I really, I don't come at this research as an advocate necessarily. I have seen my views shift a lot over the course of the research. So I was very much in favor of medical aid in dying when I started the work. And then, as I start to kind of get more familiarity with the arguments on both sides, I began to see that this issue is very nuanced and much more complicated than I had anticipated. And so I really approach it with some ambivalence, because I think it is a really wonderful end of life option for a lot of people. But I think that it is not probably the way that we can make death better for the most Americans. And that worries me. I mean, so this is why I say I'm ambivalent. I don't think it means that we shouldn't have it as an option. I've been absolutely blown away by the lives that it's touched and sort of the impact that it's made on a lot of patients and families. But I think it can also detract attention from other kinds of issues that might be more likely to promote end-of-life choice or good dying for a larger number of Americans. And that's where some of my ambivalence comes from. So I see my role as a social scientist, and I see my role as to kind of raise new questions that have not been asked about this practice. And how those findings get taken up by advocates on either side of the debate, it's a really interesting question, but I guess I don't see myself censoring my work, because really what I want to do is kind of change the kinds of conversations that we're having. And so my role is not so much to censor or to worry about how the findings might get used or misused, but to sort of put this out here and hope that it will help people ask different kinds of questions about this practice.
Mm-hmm. Thank you. I mean, and we kind of discovered you because we saw your article, your letter to the editor in the Daily News, I believe it was, in support of New York's medical aid in dying. But it's important that you're kind of having this important conversation. So I see another question here. In the conversations you had with the physician, someone asked, did you find a relationship between the age of the doctor and their willingness to prescribe the medication?
That's a great question. I have to preface this by saying that, my sample is pretty small. I think I had something like 12 or 13 physicians that had participated. And so we can't really draw definitive conclusions from that size sample. I did not see a strong signal regarding age of the physician. The kind of signal that I did see, however, which I can share with you sort of cautiously, is a gender signal. And the physicians that were prescribing in Vermont were much more commonly women than men. And again, there's only so much we can make of this pattern because it's a fairly small sample, and who knows what's happening in other larger states. But the sense that I made of this with my data was that it seemed like women who might have some kind of objections to medical aid in dying, or who might have some resistance to medical aid in dying, were more likely to prescribe despite those reservations out of concern for not abandoning their patients. Whereas the men physicians whom I interviewed who had prescribed, they didn't have as much ambivalence about the practice. They were sort of more cut and dried, like, well, this is just an extension of my role as a palliative care physician, and it's very much in line with the other work that I do in my practice. And they didn't sort of articulate a moral conflict in doing it. So I think more work needs to be done, really sociologically, to understand if there's really a clear pattern there. But if I had to say whether there were demographic patterns in my data regarding physicians' participation, I would point more to gender than to age.
Okay, thank you. Another question here. Can you address what kinds of other improvements in end-of-life care are pushed aside by advocacy to pass medical aid in dying laws?
Sure. So one example, this came to me from a hospice social worker whom I interviewed for my research, and she told me, I resent how this has stolen time from other issues. And what was explained to me by her, and also by some other policy stakeholders in the state, is that Vermont had actually not adopted a surrogacy law. And they have one now, but at the time that I was doing this research, they had not yet adopted a surrogacy law because they were putting that on hold while they were waiting for this legislation to be passed. So that's just one small example. And a surrogacy law, I should say, sort of articulates a hierarchy of who, which relationships to a patient should be in a position to perform end-of-life decision-making if a patient becomes incapacitated and can't decide for themselves. So, I mean, that's just, it's one small example, but I think the argument that some folks have made is that the advocacy dollars that are spent around legalizing medical aid in dying might be spent on other kinds of policy changes that would expand access to good hospice and palliative care, for example. So that is one argument that is out there.
Okay, thank you for elaborating on that. We have an insurance-related question. Are there any private insurance companies which cover the medications? It seems like people with lesser means won't have access.
Yeah, some insurance companies have covered it, and I don't have details about which those have been. But yes, some have been willing to cover it. Now, there was, I don't know if anyone's seen the movie How to Die in Oregon, which is a great documentary film that describes Oregon's death with dignity law, but there was a case that was covered in that film of a patient who was denied experimental chemo. He was a Medicaid patient, and yet they offered to pay for death with dignity. And, that of course is highly problematic. So it should be a both and. It should be access to treatment, and it should not be paying for medical aid in dying when other forms of care are being denied. And after he went public with that experience, the Oregon Medicaid program changed their mind and did agree to pay for his chemo. But yeah, there is a worry that this may be more available to more affluent patients. And I think it's not only, or even at this point, primarily because of the cost of medication, because there are much more affordable drug cocktails that are now in place. But it's because of the sort of savviness, as one of the physicians described it, that is necessary in order to, to find the physician. So who has access to physician networks and knowing which physicians might be likely to prescribe, and then who has kind of the health literacy to go through what amounts to a fairly complex bureaucratic process. That's one way in which more affluent patients might be more likely to get access to medical aid in dying as well.
Mhm. And then that kind of relates to a question we have around primary care and the role of primary care. So this person asks, if the goal is to normalize it within primary care, I believe states need to follow the lead of New Mexico law, whereby all end-of-life options are reviewed with patients and healthcare institutions to show on their website they support medical aid in dying. So I guess that was not a question, but a statement. So what do you think about that?
Yeah, absolutely. I mean, I think that if this is going to be a legal option, I think that all prescribing medical providers should be able to prescribe it, and there's absolutely no reason why it should be a physician and not a nurse practitioner doing it if nurse practitioners are permitted to prescribe other medications. I absolutely agree with that.
Mhm. Yeah, and then here's another question. Are there any organizations working on the inequality and access issues that you know of? And did your research touch on the disability justice community, who generally are opposed to medical aid in dying for sometimes good reason?
Mhm. Yeah, organizations opposed to, or organizations working on the inequality issue. I think that there are some state-based advocacy organizations in Vermont who have been disturbed by my research, and don't love the message that I'm putting out there, that access is a problem. And I think they have been working on it, particularly since some of my stuff has been coming out. In terms of the disability rights community, yes. I mean, I interviewed a lot of the disability rights activists in Vermont about their reasons for opposing the law. And to be honest, those concerns and their arguments are some of why, the commenter wrote that they've opposed sometimes for good reason. And I agree with that. I mean, I think some of their concerns are partially responsible for my waffling a bit in my views on medical aid in dying early on in my research, because there's this basically to articulate their concern for those that might not be as familiar with their arguments. The worry is that if we say we are going to make it an option for people to say, I don't want to live with this quality of life anymore, I don't want to be dependent on others at a certain point, then what kind of a value judgment are we making about people who depend on that kind of care every day just as a condition of their existence? I think those are powerful arguments, and I think they have often been articulated more persuasively than the arguments of proponents of medical aid in dying, to be perfectly honest. But I think ultimately there is absolutely no evidence of a slippery slope by which we are going to make it more likely that people with disabilities are going to be subject to death against their will. I mean, there's just no evidence of that, particularly because we have the self-administration requirement in the US that makes this be a voluntary choice by an individual patient. But I do understand the passion of those advocates and the very real concerns that they have.
Mhm. And given all the safeguards in place and all the challenges they pose, how would you edit the medical aid and dying laws across the country to facilitate access?
Good question. I think the waiting periods in most cases are probably unnecessary. I understand there's this idea that this is not something to be taken lightly, and this is not something that people should rush into. But the reality is that most people, when they actually come to the point where they're making this request to a physician, they've been thinking about this for a very long time. This is not something that they just woke up that morning and said, you know what, I've changed my mind. I don't want to live anymore. Like this is kind of after the end of a very long process. So I'm not sure that the waiting period does a lot except create bureaucratic hurdles.
Mhm.
That's one that I would change. I think I probably would be an advocate of removing the self-administration requirement as well, because I think that things have gone more smoothly in Canada, where there is an option for physician administered medication in addition to patient administered medication. I think that, when a physician attends these deaths, things tend to go better. I don't see that happening in this country, so I'm not even sure it's worth kind of considering as a viable option. But I think that it would include a much bigger population, and perhaps also raise the hackles of the disability rights community as well. But it would equalize access so that there's not this sense of, this really works if you have cancer, but maybe not for other kinds of conditions.
Mhm, mhm. Thank you for that. I have a question about kind of education. So what are your thoughts on promoting end-of-life care education at university level or other healthcare entities in terms of doctors, nurses, social workers?
I think it's really important. I'm a professor in a school of medicine, and I teach a class on death and dying in America to second-year medical students. The kinds of conversations that I have with my students, they often tell me they don't have elsewhere in their curriculum at all. And this is worrying because I teach a small elective. It's not a course that all of the students get, but we really think about some of the cultural dimensions of death and end of life care. So not necessarily just the nitty gritty about how to deliver bad news, which of course is important, but they are taught that in their clinical skills classes. But just kind of thinking more broadly about why is it that physicians are socialized to, avoid acknowledging that death is inevitable and to see death as defeat in some way, and sort of to grapple with concepts of mortality. I make all of my students interview a loved one about their end of life wishes and do some advanced care planning. And they are so grateful for that push to kind of have those kinds of conversations. And I think having those conversations at home with loved ones will only make them better clinicians. So yes, I think education of medical professionals is so important. And I think there's so much more work to be done.
End of Life Choices New York is going to launch a certificate program to help people gain more knowledge and skills and help advocate for members of their community, particularly around advanced care planning. So what other people in the community, what other roles in the community do you think should be educated about this issue, given the fact that we have challenges with our medical care system? We maybe have 15 minutes with our doctor. Where should some of this information lie? Who do you think would be a good audience to educate outside of the medical system?
People, the lay community and probably older adults I think that all Americans should be better informed about end of life issues and sort of become more accustomed to talking about end of life issues. But certainly I think older adults are more willing to take this on and to recognize that this is an issue that is going to be coming their way sooner rather than later. So yeah, I think it's really important, and you're right that we probably can't sort of just wait for medical professionals, that these conversations have to be happening out in the community as well.
Yeah, with people they trust and
Yeah,
actually go for information, faith-based communities and community-based organizations and those kinds of things.
absolutely.
Let me see enough, miss all the questions here. We kind of answered that one. How do you think we can encourage a wider range of people to have end-of-life planning conversations before they get sick and know about what their end-of-life options are?
Yeah, it's a tough question. I mean, there are lots of initiatives like Death Over Dinner, which is an initiative to try to get people to have conversations with their family members over holiday meals like Thanksgiving and things like that. Uh, I think there's a lot of good films out there that are good for sparking discussion and conversation. I mentioned How to Die in Oregon, which is one that's specifically about medical aid in dying, but I think there are others, and that can be one way of going about this. Books and book clubs, Being Mortal has had such tremendous success with the public, and I think there have been a lot of book club discussions organized around that book and other books like it, sometimes through public libraries. So we have to think creatively, and some of this I think is really hard in COVID times because we're just not having as many public events. On the other hand, there's been a real growth in online activities and social movements online. And so there is an opportunity there to connect with people with like-minded views and shared interests through sort of new media kinds of connections.
Mhm.
So I don't think I have a terrific answer here, but I agree it's something that we need to be working on.
Mhm. In End of Life Choices New York, we're working to engage the communities that haven't been traditionally engaged in these conversations. Younger people, immigrants, people who speak other languages. We're doing a survey right now with Black New Yorkers. Any thoughts about how to engage those communities in kind of a different way? Also thinking that maybe their diagnosis process is a little different. Maybe they're getting a late stage diagnosis. They don't have the same time frame. And there's other issues leading to their death, injury, all kinds of other things. So any thoughts about how to engage those communities?
Yeah. Meeting them where they are. So, you've mentioned faith-based communities and sort of partnering with faith organizations. I think that can be really helpful. I know, like here in the South, I have colleagues that do work on African American communities, and they do things like partnering with barber shops to for certain kinds of interventions, like traditionally African American barber shops. And I just raise that as an example of kind of thinking creatively about how to find people out where they are and to latch on to existing programs. But I think first, what's really important, and End of Life Choices New York is already doing it, is listening and finding out what people are thinking and what people are wanting, and then tailoring programs and interventions to those ideas. So you have to start with the surveys, right? You have to start with figuring out like what is out there, what do people want, what do people know? And I don't know these communities well enough to be able to say, but that's where I would start, I guess, as a researcher, would be just kind of gathering information and learning more, and then figuring out how we could be impactful.
Mhm. Thank you for that. I see that David Levin, who works with End of Life Choices New York, said that the New York bill does not include a waiting period. So he just wanted to mention that in
That's
terms
great.
of. So just seeing if anybody else has any questions. Someone did ask, what are the next steps in your research? What do you hope to do next? What do you hope to study next?
So I'm not working on assisted death right now. I've actually been doing research looking at COVID and frontline physicians and how they're managing stress, dealing with care for hospitalized COVID patients. I have been working in 4 cities actually who are hit really hard. One of them is New York City. And there's a big end of life component with that research as well, because a lot of what physicians are talking about is kind of the sheer volume of patient deaths that they're confronted with and how challenging that was for them. And so I'm seeing a lot of connections with the work that I did around medical aid in dying, and I think I should say that the pandemic and the lack of control over the dying process that was really brought home to so many of us during the pandemic, that has helped me see some of my findings in a new light. And that's part of why I kind of raised these questions. I finished this book during the pandemic, and it's part of why I raised these questions about like who has the privilege of control and who has the privilege of planning, because we've seen how difficult and how impossible that has been for a lot of people during this time.
So what do you think will be the long-term impact of COVID on the MAID conversation and other end-of-life option conversations?
I think COVID has had a really positive impact on goals of care conversations and kind of advanced care planning in a general sense, because it has made clear how indispensable the work of palliative care physicians is in having those conversations. I mean, these physicians were working overtime and still are, just trying to figure out in really challenging situations what people want. And I do think that will have a spillover effect. The impact on MAID, I'm not sure. The relationship is a little bit less clear to me, but I think perhaps we'll see, this real assertion of the importance of choice and control when it's possible.
Mhm, mhm. For that. And then we had a couple of questions kind of about, I guess, when there's lack of cognitive capacity at the end of life, dealing with Alzheimer's patients and stroke victims. Your thoughts about that?
Yeah. I mean, dementia is kind of the big elephant in the room when it comes to this issue. I was part of an expert work group organized by the Hastings Center to deal with the problem of dementia and dementia patients being left out of this conversation about medical aid in dying. And it's just not compatible with the current legislation in the US, because at the point at which death is expected within 6 months, people with dementia are no longer competent to decide for themselves. And I don't see a way out of that, to be honest. I think the option that would be available to people with dementia would be voluntary stopping of eating and drinking. And I know that that's an issue that End of Life Choices New York has covered recently as well, with some of my colleagues who have worked on that issue.
Mhm. Thank you for that. See, we have like 2 minutes left. So if anybody wants to get a burning question into the chat. So someone asked about, who's a chaplain, asked about how, if you've had presentations or conversations or workshops with chaplains and their role in this.
I have not. I did interview one chaplain during my study, a chaplain in Vermont who had some interesting perspectives to share, but I have not shared it kind of more generally with that audience. And I think that, chaplains are so instrumental in many hospital settings to providing psychosocial care at the end of life. And it would be really interesting to kind of get their take, but it's not a community that I have directly engaged in a mass group.
Mhm. Okay, great. Well, we're coming to the end of our time. I wanted to thank you again. I know if we were unmuted, you would hear applause right now because this was really fascinating and informational. I can't even talk. And people are saying that they learned a lot. A lot of questions were answered. Now they have other thoughts. But I just wanted to plug your book before we go, which I was reading. Scripting Death: Stories of Assisted Dying in America. You may be purchased for 30% off using the coupon code that you'll get in your email. And then if you want to reach out to Mara directly, she has included her email. We can include her email in our email we send to you tomorrow, but she's open to questions and conversations. So she encourages you to continue the conversation that way if you'd like to. But I just wanted to thank you again for your time this evening. We're really excited to have you, and I've learned a lot. I appreciate the
Thank
opportunity.
you. I mean, thank you all for your attention. This has been wonderful, and I'm happy to be in touch if anyone wants to continue the conversation.
Thank you so much. All right, and thank you for all who attended tonight. Thank you for sharing a Wednesday evening with us. We appreciate it. Take care.